Thanks so much for having me. So we're going to step back from the microscope and go to clinic and see the patients. Well, really go to radiology and see some of the clinical things that are happening to these patients and how we're trying to deal with them while you all are doing this amazing work that I think will be the future, and we'll work in tandem together. So this is what's happening sort of day to day right now. And I'm going to take you a little bit on our journey as well as how we got to where we are and sort of where we think we're going to go. Very basic lymphatic anatomy. So retroperitoneal system to your cisterna chyli in your upper abdomen, up your thoracic duct to your left subclavian vein. And currently we have access to the retroperitoneal system from your lower extremities, the mesenteric system, and the hepatic lymphatic system. And as you guys have heard, we really weren't able to visualize the lymphatic system until about 2010. And the concept of intranodal lymphangiogram was created and published, where we take a 25 gauge needle, advance it into a superficial lymph node under ultrasound guidance. And this gives us a stable access in order to introduce contrast agents, different contrast agents into the lymphatic system so we can actually see what's going on. In this picture, this is us just injecting water-soluble contrast under fluoroscopy. Once we have the needle in, we just want to confirm that we're in the system. And you saw before, this is ultrasound-guided contrast. The bright stuff is the contrast, and you can confirm that you're going up the lymphatics, it's going up, and that you're in the correct spot. And just as a reminder of how complex the lymphatic system is and why we couldn't see it before, this is a sort of the same level. This is the para-iliac region in the pelvis. And you could see this is a lymphangiogram with Lopidol. You can see how complex and small these vessels are and how simple. And this is the arteries and a CTA. And this is why it's been so difficult to actually visualize what's going on in these patients. And so just being able to even see this is a huge step. And just as a reference, because I'm going to be showing you a lot of abnormal MRs, this is a normal neonatal MR lymphangiogram. So newborn lymphangiogram, normal thoracic duct. It should go up, it should be very thin, not too tortuous, and make that nice candy cane into the left subclavian vein. Some infants are too small to tolerate going to the MR scanner. So if you have like a less than 3 kilogram baby and you really want to get some imaging, we've solved that with using cone beam CT. This is a 3D CT image that we can create on our interventional radiology machine. It takes about 5 minutes to do. We inject water-soluble contrast again into the lymphatic system, and you get a very nice view of the thoracic duct, which can also be reconstructed into a 3D view, which is nice for showing people. And so that takes away the problem of going to MR, because the MR takes about 45 minutes to an hour, and those very small babies can't tolerate that amount of time in the scanner. Everyone else kept going by accident, and I can't go forward. Okay, so I'm going to get into some pathology now. This is an MR lymphangiogram of an 8-year-old patient who has central lymphatic conducting anomaly. And what you can see, this is what we call a pathognomonic. We call this a pathognomonic imaging. This, instead of going up into your thoracic duct, you have, this is MRI gadolinium contrast going into your dermal lymphatics, going retrograde down into your lower extremity lymphatics and dilating, sitting in your retroperitoneal lymphatics. And this patient actually presented as chylous pleural effusion, but really was a chylous ascites in origin. And she was leaking into her sort of basically the retroperitoneal space, and that was then transferring to her chest and to her peritoneal space. And this is a 3-year-old patient who had gopociform lymphangiectasia. This patient had presented multiple times needing resuscitation after life-threatening cardiac tamponade from pericardial effusion. And then once they did a pericardial window, had multiple large pleural effusions necessitating chest tubes for basically his whole life. And so this is what you can see here. You see this dilated, extremely ectatic, disorganized trunks of lymphatic fluid going forward, and then also going out into where it shouldn't go, retrograde into the lung, retrograde into the mediastinum. And the other thing you note is that these patients have large amounts of fluid. So they're, even though this looks terribly dilated and you would say this is an obstruction, these patients are actually, their fluid goes faster, enters the venous system faster than most patients. And we think the dilation is actually from overproduction of lymphatic fluids, maybe at the level of the capillaries. And this is another patient. This is a neonate, a 1 week old, who actually just presented with the Noonan syndrome. So the patient had in utero pleural effusions, kind of went away, came back, has had a couple of weeks of pleural effusions that they couldn't get rid of. Really no other symptoms, no edema and no ascites. But again, you can see this markedly abnormal lymphangiogram demonstrating stasis in the retroperitoneum, retrograde flow into the intercostals, the mediastinal, and the pleural lymphatics, and stasis up in the neck where it should be entering the venous system. Eventually, the patient developed pulmonary hypertension and cardiomyopathy, which helped the clinical team understand the Noonan syndrome. And so one of the questions I ask a lot is, are there phenotypes to, imaging phenotypes to each of these separate clinical diagnoses, right? So we have central conducting lymphatic anomaly, mucosiform lymphangioma, and angiomatosis, and then Noonan syndrome. And they look fairly different on this. However, when you start to try to look at a specific MR lymphangiogram and say, oh, it's going to be this, it's very difficult to do because, as somebody mentioned, I think a patient mentioned, they're each very different and they each present differently. So this is a patient, I think she was 3 or 4, who came to me with, there it goes, generalized lymphatic anomaly. You can see that she has lymphatic malformation in subcutaneous tissue. She has a combination of pleural fluid and lymphatic malformation in her chest. Her spleen is large and filled with these T2 hyperintensities. And this is an 18-year-old who came with Gorham-Stout disease. You can see the bony loss here in the darker vertebrae. You can also see her spleen is abnormal. This is a different sequence. It's T1, so the little bright spots are dark here, but she also has this abnormal spleen. And these were the MR lymphangiograms. I just showed you still images from these. And they look actually fairly similar, right? So all of a sudden you're seeing a single thoracic duct. It's getting dilated at the top. You're seeing a single thoracic duct. It's dilated at the top. But if you go back and you think about the mucosiform lympangiomatosis patient, which we equate more with generalized lymphatic anomaly, I would have expected them to look more similar, and then Gorham-Stout to look different than GLA and KLA, but that wasn't the case. So what we need is more numbers and registries and more, just more images of these patients who actually have diagnoses to try to figure out, can we do a non-invasive imaging of these patients? This is another patient who was born with a left chest wall lymphatic malformation. He also had extension into his retroperitoneum. You could see it pushing on his kidney, but no visceral lesions. So he was just billed as a lymphatic malformation. We biopsied it. He was PIK3CA. He did have a PIK3CA mutation. So we did sclerotherapy of this large retroperitoneal portion. And then he was put on alpelisib eventually. And his thoracic duct is, this is a baby. So this, although it looks kind of in the configuration it should. It's too dilated. It's too tortuous. It's making too many turns. So this is what we call, what we assume is a obstructed thoracic duct. And so once we started getting images and started classifying diseases, our next step was, well, what do we do now that we know this? And we needed to get access to these systems. And I like to show this slide because it's a very honest slide. And this is how we access the thoracic duct. So we take a needle and we go from the abdominal wall through whatever's in the way. And, and we insert it into the thoracic duct. My partner, Mexican, initially taught me this, and I was like, I'm not doing that. That sounds like a terrible idea. But it's incredibly well tolerated. We use very, very small needles, 25 gauge needles to start. And the patients, I had a patient go home just yesterday from a Thursday procedure. They tolerate it extremely well. So what we do is inject Lipiodol into the groin nodes typically until we see the cisterna chyli, which is in the mid-abdomen. So here we have very nice visualization of the cisterna chyli. We take that needle, and this is what it looks like in real time. We take the needle, we advance it into that area, and we advance a wire until it goes up the thoracic duct. And once we do that, we exchange the needle for a microcatheter, which is this little guy going up. And now we have nice stable access to the central lymphatic system. We can evaluate it and we can intervene. And this is what a normal person's thoracic duct lymphangiogram looks like. Very thin, very little tortuous, but not really. And you can see the outflow into the left subclavian vein. I'll play that again. Look up here and you'll see the contrast starts to go down and rapidly dissipates because it's being diluted by the blood, but that's it entering the venous system. So moving on to central conducting lymphatic anomaly, and this is the diagnosis that tells me we don't know enough yet about these patients. We've discussed how they present as non-immune hydrops with chylothorax, chylosocites, and anasarca. And so in infants, what we found is we just call this altered flow in the thoracic duct. But we found 3 different underlying reasons for this. So you can have thoracic duct dysplasia, you can have an obstruction of the duct, or you can just even have elevated central venous pressures. And I'll show you this eventually. Okay. So this was a newborn with non-immune hydrops, had very bad edema, ascites, pleural effusions. His MR lymphangiogram looked like this. You can actually see the contrast going out of his peritoneal drain here, and as it leaks out, but obviously you can't see a point where it's leaking out. It's just everywhere. His entire lymphatic system is dysplastic. And so when we see this, we take them to IR and we inject the needle where the thoracic duct should be, even though we don't see the thoracic duct. And here you can see we are in the lymphatics. These are intercostal lymphatics. And he just has these 2 extremely hypoplastic, dysplastic chains that are traveling up his vertebrae with little interconnections. And we don't have a solution for this from an interventional standpoint. This is another baby who presented with similar symptoms. So had non-immune hydrops, similar symptoms. Here's the MR lymphangiogram. Again, you see the no thoracic duct. You're seeing retrograde pooling back into the vulva here, and the labia, into the skin as well. We call that dermal backfilling. However, when we put the needle where the thoracic duct was, surprisingly, he had a very nice, beautiful thoracic duct. It had just been obstructed. And this is another patient. This patient had a very rare skeletal dysplasia, which I was taught as a resident was not was lethal in utero. It's called thanatophoric dwarfism, and you can see that the shape of his lungs is very narrow. His chest wall is extremely narrow, and this is an MR. So all of this bright signal is subcutaneous edema. And on his lymphangiogram, I just showed you this part because he was very tenuous and we didn't do a whole MR or anything. You see a very dilated thoracic duct. This is actually his mandible, and it's just taking a complete U-turn. So it was a combination of his anatomy. So his thoracic duct was coming up here instead of here, and also elevated central venous pressure. So that his chest his chest was so small that he had obligate elevated central venous pressures. He then was put on respiratory support, and as his respiratory support would have to go up, his lymphatic problems would increase, and as his respiratory support decreased, his lymphatic problems got better. So it wasn't that he wasn't connected. It wasn't that it was innately abnormal. It was just this elevated central venous pressure from his body habitus. And so here's our same patient with caposiform lymphangiomatosis. Just as a reminder, that's his MR lymphangiogram, and here's his catheter lymphangiogram. So you see this markedly dilated, markedly abnormal thoracic duct, and you're actually seeing the frank leakage into the pericardial space right here. This is just contrast leaking. This is the source of what is happening with him. But you also see, this over here, this over here. This whole thing is completely abnormal and not functioning. And we know that in these patients, when they start to present with these pleural or chest problems, that they have a very poor prognosis from that point on. And so for this patient, he was kind of in a dire straits, and we did what we do, which is we blocked off what we thought looked at the most abnormal. We ended up blocking off both of his ducts, but to block it off, we have the catheter in this duct. We release a little coil packet over here, and then we follow that with glue, some kind of either histoacryl or N-butyl cyanoacrylate. They both polymerize when they touch ionic substance, so they immediately polymerize and stay there. And he did great. He a couple weeks later had his chest tubes out. He went home. Unfortunately, he later, I think, got COVID and didn't have a great outcome after that, but he had lived at least a few months without those chest tubes. And I'm sorry, this was also his MR. So this is before we did the procedure with the embolization. This is post-contrast T1 weighted image. So you can see the contrast is all around the heart in the pericardial space. And this is a follow-up lymphangiogram we did. And you can see no further contrast has leaked into the pericardium. And it's all remained inside of the heart. You can see the difference in the blood volume once that lymphatic fluid gets returned to your system and is no longer just collecting in random spaces. This is a teenager who had, as you can see, very severe Gorham-Stout disease. She actually had done very well. She was about 18, but had a lot of, bony loss. And she presented with about 5 liters of chylous pleural effusion output per day, which is a lot. And this was her lymphangiogram. So, it doesn't actually look too abnormal, but what I would like to point out is just this little area of abnormality where there's a little contrast going off to the right. And so when we finally we took her back to IR and we put a catheter in her, and you could just see this little vessel going off here and causing all of this accumulation. And that little vessel was the cause of all of her chylous effusion, the 5 liters per day. And so as somebody else mentioned, what are we doing? Are we just blocking things off and we're going to cause problems later? So we try to save the thoracic duct if possible for future interventions, and so as not to burn our bridges. So for her, what we did was a selective embolization. So we could see a culprit vessel. We put a catheter. So this is the initial injection. You could see this little branch coming off. We couldn't access it from the below because it kind of went like that. So we snared our wire and put another microcatheter and brought it down. So here we have 2 microcatheters. We call this the antegrade one and this the retrograde one. And we are selecting that little branch. Oh, we're selecting that little branch, and we delivered a little bit of glue into that branch. At the same time, we injected D5W into the antegrade catheter to prevent the glue from touching anything ionic like blood. And we were able to maintain her thoracic duct patent. So this is her at completion. You see no more leaking, and her thoracic duct has remained patent. And she's actually done very well as well. She had her chest tubes removed, and I haven't heard from her in a couple of years, which is good. She's doing well. What? All right. Oh, I'm sorry. And this is her repeat MR lymphangiogram, and you can see you got much better visualization of that thoracic duct. That flow has now been restored from that leaking point, from that potential space back into the lymphatic system, and then therefore back to the venous circulation. Oh, okay, sorry. Well, I got too excited. Anyway, this was a patient, so we want to move on to lymphovenous anastomosis, where we reattach an obstructed thoracic duct to the venous system. That's what this is. And basically, this is just a post where you can see an obstructed thoracic duct has been reattached to the venous system. We can do liver lymphangiography. We can do mesenteric lymphangiography at this point, and skip that. So in the future, can we diagnose underlying disorders with lymphatic imaging alone? I would say no at this point. We don't have that ability yet, but maybe in the future with bigger numbers. We need to determine who's a candidate for thoracic duct sparing and complex lymphatic anomalies. Can we develop better non-invasive imaging agents? And can we combine imaging with treatment for direct delivery of medication? Thank you.